Well, thank you very much, and good afternoon, everybody. My name is Clifford Coe. I'm a surgeon at UCLA, professor of surgery at UCLA, and I also work at the American College of Surgeons, and I'm the director of all the quality programs in the American College of Surgeons, and one of the quality programs is the NSQIP, the National Surgical Quality Improvement Program. And so I will tell you about our experience about NSQIP, and and hopefully this will help Korea develop their own NSQIP that's even better than what we've done. So I will start here with this first slide, and this is a slide that I usually like to start with, and it's called the Golden Circle. And this is really for businesses, and it describes that in a business like Apple or General Electric, most everyone in the company knows what they do. Most everyone. And then a smaller group knows how they do it, but the smallest group knows why they do it. And if we think about why and why we had ACS-NSQIP, when we started ACS-NSQIP over 20 years ago, there was a few reasons why we started ACS-NSQIP. The first is that we wanted to measure surgical quality. And at that time, the most important thing for us was to measure the occurrences or the complications or the problems we had up until 30 days after operation. So that was one of the first reasons why we wanted to have ACS-NSQIP. Another reason was that we wanted to provide comparisons across the United States to identify opportunities to improve. So we wanted to benchmark and compare hospitals so that we knew who was doing well and who was not doing well, and that we can improve everybody through comparisons. We also, once we identified the opportunities, we wanted to have quality improvement to achieve better patient care. So once we found the opportunities, we wanted to do and support quality improvement, which we are finding is not so easy, but I'll get to that later on in this presentation. And then the fourth thing is that we wanted to advance science. We wanted to conduct research and advance our knowledge about surgery, surgical care, and quality. So these four things are why we started and continue to do ACS-NSQIP, and I think that probably very similarly in Korea, that these things will also be important goals for the registry. If we really talk about what is NSQIP and what it has become and what we think is very important, there's a number of things that we have. So it's a data registry that produces risk-adjusted outcomes. If we compare outcomes between two surgeons or two hospitals, we want to take into account that there are different patients and different severities of disease or different diseases. And so we have to adjust all the risks so that we can have a fair comparison. We also found it very important to use clinical data. In the United States and in many areas around the world, there is billing and coded data. The most common is ICD-9, or the International Classification of Disease, ICD codes, which a lot of countries use. And we've done some studies, and I'll show you one where we compared clinical data from the medical record to ICD-9 coding and the differences that we found. We also found it very important to have strict 30-day follow-up, not the patient and just what happened in the operating room or just up until discharge, but for 30 days. And we made that a principle that we wanted to follow since the beginning of NSQIP, to follow the patient for 30 days. And we've asked, do we need to follow a patient for 30 days? Don't most things happen when they're in the hospital or within 10 days or 2 weeks? And I'll show you some data to show why we did it at 30 days. We know that having accurate data is very important, so we have a trained data collector, which we call an SCR, Surgical Clinical Reviewer, SCR. And this person is trained. We train them with education, and we test them every year to make sure that they are understanding what we're doing as we make changes in data and definitions, that they understand all those. And so we have a trained data collector that is annually or yearly tested. We also conduct data audits. So when we get back the data from hospitals, and we have hundreds of hospitals that participate, we will do random audits. We randomly will go to a hospital and make sure that what they're giving us and what we would find is the same thing. And so we validate the accuracy of the data. And so the data audits are very important. It's important that we have multi-specialty. So just as an example, we have hepatopancreatobiliary, we have orthopedics, urology, general surgery, surgical oncology, cardiothoracic, transplant. We have all types of specialties that we have within NSQIP. As far as giving back the reports, we have benchmarking reports that we do quarterly. Every 6 months, we redo the analyses, and then we give smaller reports back quarterly. But we have benchmarking reports where a hospital can see how it compares to all these other hospitals every quarter. But we also have on-demand individualized site-specific reports daily. So I will show you what these are that you can look at how you're doing longitudinally every single day as you put data in and how that changes. We have tools for improvement. So once a hospital or a surgeon or the surgical team identifies areas for opportunities to get better, sometimes they're not so facile, or they have not been formally trained in how to do quality improvement. So we've developed a number of tools for quality improvement. We've developed a number of tools just to help clinical care, such as the risk calculator, guidelines for decreasing things like surgical site infection. We have case studies that we've written about hospitals and how they've achieved improvement. All these different tools that if a hospital wants to do something to get better, these tools help these hospitals and these surgeons and surgical teams. And then finally, it's a research database. And so it is a de-identified data set. So there's patients cannot be identified and the hospitals cannot be identified. And we offer this data set to the hospitals and sites that participate in NSQIP. So we call it a participant use file, or PUF. You might hear me say PUF all the time, and that's what I mean, the participant use file. So if you look at the first 5 things that I've talked about, it's really to get accurate data. If we don't have accurate data, then nobody should use it, because if you can't trust the data, then it's really no good. So we spend a lot of effort making sure that the data are accurate. It's across many specialties. It's not just general surgery or not just one type of specialty, but across multiple specialties. The benchmarking reports are very important, because once you get the data, once you analyze it, we have to give it back to the sites, and they have to be able to understand it, whether it's every quarter or every day, depending on what they need. So feedback, private benchmarking comparisons is very important. The tools for improvement are very important, that individual local places will know what to do with the data, act on the data, and get better. So provide tools to help improve. And then finally, research and support research, because it's very important for us to really continue to advance our knowledge and then share that with the country, with other surgeons, with perhaps the world. So these are all what NSQIP is. So I'm going to go through a couple of questions that I know I always get asked all the time. And so maybe this will help some things as you're thinking about developing a Korean K-NSQIP, and so hopefully these will help. So is it important to risk adjust? How important is it to risk adjust? And so risk adjustment is essential when comparing outcomes. If we have 2 outcomes like mortality rates or length of stay, we have to obviously take into account risk. So here's an example. When we rank hospitals 1 to 44 by unadjusted outcomes, you can see there's red, that's number 7, and orange, that's number 37. But if we take into account the risk of the patients, that they might even change their order so that the red one becomes number 39 and the orange one becomes number 8, because maybe the orange one, unadjusted, is taking care of sicker patients, more severe disease, older patients who have more comorbidities. But once we take that into account and we risk adjust, that's a much more fair way of doing comparisons. And so risk adjustment is very important. The first thing when we hand back data to surgeons is like, oh, my patients are sicker, my patients are older, my patients are on steroids, my patients have diabetes, my patients have congestive heart failure, and we say, oh yeah, we take all that into account, and then we do the comparison. So risk adjustment is very important. Second question, is it important to use clinical data from the medical record, or can we use billing or administrative codes to measure quality? In the United States and for a lot of countries, we have a lot of billing data because we bill all the time. We have a lot of administrative data because we have a lot of administration, and they use these codes. So this is a study that we conducted in 2012 with the government at United States that uses all these codes. If you can see, I don't know if this pointer works, but Dr. Hahn and Dr. Rapp are two doctors that work at CMS, that's Medicare, or the government in the United States that provides care. And we did a comparison of clinical data, NSQIP, to the coded data. And we took 100,000 patients and we used their clinical data, and the same 100,000 patients that we had their ICD-9 codes, and then we compared them. And so what we found, and I won't go through all these numbers, but basically what we found is that administrative or billing data identified only 29% of the infections. So administrative data missed over 2/3 of the infections. If we want to improve quality, we need to find all of the infections and know our whole total problem, because if it's only 1/3 of the problems, then we might not think it's a big problem. But if we had to multiply it by 3 and find all of our surgical site infections, which is the most common complication that in surgery across all the procedures, then we need to find all of them. Also, we found that 48% of the surgical site infections in administrative data were not present. So in the ICD-9 codes, they were saying that something was an infection, whereas in the clinical data, it wasn't an infection. So half of the surgical site infections in administrative data were false positives. So it was telling us there was a problem when there really wasn't a problem. So that is a problem as well. And so this study demonstrates the inaccuracy of coding, and ICD is the International Classification of Disease. So these are international used codes, but for evaluating surgical quality, the inaccuracy was too high. And so we know, at least in the United States, the surgeons do not want to use ICD coding or billing codes or administrative codes for evaluating quality in the clinical care that we give for our patients. So clinical data are important. ICD coding, administrative coding is not good enough for what we want to do. Another question, how long after operation should we collect data? We currently collect data for 30 days after the operation. So if it's January 1st, we collect up until January 30th. But can we change to have less follow-up? Because following a patient for 30 days is not easy. If they go home on post-op day 5, maybe, there's another 25 days that we have to follow the patient. They might be at home, they might be somewhere else. We have to follow the patient for 30 days. Can we follow them for up until 2 weeks or 1 week, or up until discharge? And so let me share you with some data that we are currently looking at this to see how we can do things easier. But these are the days to detect 75 to 95% of the occurrences. And I don't think we've published this, but so this should hopefully be interesting. We looked at the last years of cases in all of NSQIP, which is almost 1 million cases. And I'll give you an example of this outcome, superficial surgical site infection, and then I'll show you the rest of the data. But for superficial surgical site infection, there were 17,414 SSIs that were identified, which is a rate of 1.77% in all of NSQIP. These are colectomies, these are hernia repairs, these are mole removals, all types of cases that are in NSQIP. If we wanted to find 95% of all these SSIs, we have to follow the patient for 28 days. So they're occurring out that way. If we want to only identify 75% of these, we can stop at post-op day 20. So you can see that even getting 3/4 of it at post-op day 20, if we're happy with only 3/4 and missing 1/4 of the superficial SSIs, we can stop at post-op day 20. If we want to get 95% of it, we can stop at post-op day 28. Here are the rest of the outcomes that we measure in NSQIP: deep incisional surgical site infection, organ space, wound disruption, dehiscence, pneumonia, unplanned reintubation, so forth, UTIs, urinary tract infection, stroke, or CVA, cerebral vascular accident, cardiac arrest, all of these things. The only things that really you can stop very early are blood transfusions, where, yeah, we transfuse patients pretty similarly, or at the time we do operation and maybe a few days after that, but usually not up until 30 days. And the other one was septic shock. When we operate on sick patients, and this is including emergency surgery for example, perforated diverticulitis, perforated appendicitis, cholecystitis, emergency surgeries, acute care surgeries, then a lot of septic shock occurs earlier than the 30 days. But basically everything else, we are finding that if we want to collect at least 95% of it, it goes between 3 to 4 weeks that we should follow these patients. We came up with something. You may have heard of the Clavian-Dindo to look at severity of complications. And we came up with our own called DSM, Death and Serious Morbidity. SAR is a semi-annual report, but DSM is when we put together all the severe complications plus mortality. And for that, we know that if we wanted to collect 75% of the DSMs or severity complications, it's 16 days. And if we wanted to collect 95%, is 28 days. So this tells us that we still should, if we want to collect nearly all or 95% of the complications, we need to do it till almost 30 days. So I think we're going to keep on doing 30 days. Now, for what K-NSQIP is doing, not just based on necessarily all of these things, and these rates are pretty low because this is including all the cases that usually do not have complications at all the outpatient or ambulatory types cases and things like that. And I personally think that NSQIP is most helpful for the cases that tend to have higher rates of complications. So if I look at this in a different way, and I look at days to detect 75 to 90% of the DSMs or death and serious morbidity events by surgical procedure. So if we look at kind of appendectomy and colectomy, proctectomy, all of these things, and I tell you the number of cases and the event rate of these complications, of the DSM complications, the event rate, and so forth, you can see that that as an example, appendectomy had 49,000 cases with 1,267 events for an event rate of 2.5%. And if you wanted to collect 75% of the events for appendectomy, you can stop at before 2 weeks. 80% you get at 2 weeks. And if you want 95%, that'd be 23 days. Now, for the things that I know that K-NSQIP is doing as on this, at least on this table, for colorectal, colectomy, and proctectomy, for hepatectomy, for pancreatectomy, these are the event rates of all those other complications that I showed on the prior slide. These are the event rates. And if you wanted to collect 95%, these are the up to 24 days, 27 days, 23 days. So again, between 3 and 4 weeks. If you were, anyway, I don't know how to go backwards. Oh, here we go. And so it's between 3 and 4. If you wanted to 80% or so, and you're happy with 80%, then sometimes maybe 2 to 3 weeks you could do that. And you will have to decide and think about how much of the complications you want to see. And if they occur further out, we've done some studies that sometimes they're very severe, but sometimes they're not very severe when they occur between 3 and 4 weeks. But this is very important because there's validity and there's feasibility. The feasibility of collecting data when the patient goes further out is more difficult. And I'll show you in a little bit that if a hospital doesn't follow a patient for 30 days, if 95% of the patients or less are collected after 30 days, we don't use their data. They have to follow the patient all the way out to 30 days, basically. What should our feedback reports look like? So once we get all this data in and our statisticians analyze the data and do all this stuff to the data, and we put it into these reports, what have we found to be very useful for the surgeons and the surgical teams and the quality people at the hospitals to really look at the data, understand the data, and act on the data? So this is called a caterpillar plot. So a caterpillar, this kind of looks like a caterpillar, so that's why we call it the caterpillar plot. And we want to give data back to show how a hospital is doing and is doing compared to others. And very importantly, the report only identifies your own hospital. So when I get this at UCLA, at my hospital, we only know where UCLA is on this graph. We don't know who anyone else is. We want to know who the worst hospital is. We want to know who the best hospital is. We have no idea. We only know where we are. So this graph, the yellow dots is the hospital point estimate. So that is the risk-adjusted outcome. And then the up and down lines, the vertical lines are the confidence interval. And when the confidence interval crosses 1, then it's as expected. When the confidence interval does not cross 1, these hospitals are statistically better than expected. So they're low outlier hospitals. That's what we call them. And then when the confidence interval is above 1, doesn't cross 1, these are hospitals that needs improvement. They're statistically worse than expected. And so these are high outlier hospitals. So we have low outlier hospitals, high outlier hospitals, and then we have the hospitals in the middle. You can see that most of the hospitals are in the middle. So usually what happens is about 80% of the hospitals are doing as expected, 10% are better than expected, 10% are worse than expected. We can work with our statisticians so we can expand better than and worse than expected, but usually with a 0.05 and the way we're doing statistics, it's about 80% is in the middle, 10% is better than expected, 10% is lower than expected. We do this graph for a lot of the complications and we call them occurrences. That you saw on the other graph, and this is just, again, some of the things that we see here. Now, this is a static view. We put this report out, and we rerun the statistics every 6 months. So we do that, and this is the last year's worth of data, 6 months plus the prior 6 months put together. So this tells us how a hospital is doing for the last 1 year. And it takes, once they get all the data in, we have to clean it. Our statisticians run the analyses. And so it might be 3 months before we're able to get it back. And because we give back hundreds and hundreds of different models, mortality, readmission, but we also break down mortality into, abdominal procedures and mortality, colon procedures, mortality, proctectomy, mortality, pancreatectomy. And so we break it down, and our statisticians run probably over 500 different analyses, and so it takes them time to do it. But we've been asked frequently, can we have a longitudinal view like a run chart? So a run chart, and you might call it something differently, but this looks at some data like in the month of March and in the month of April and the month of May, and it kind of runs along, and you can have it monthly, quarterly, weekly, daily. You can use any type of interval in this for this coordinate, but it basically tells you how you're doing from time period to time period, and it allows you to see trends. And so we kind of took the data, and we can do this. And so what we've done is to do this. We call it the NSQIP risk-adjusted run chart, or the on-demand chart. And this is the one that people can see daily. They go onto the website, they push a button, and they can see up to the last 24 hours if data were put in, how these things go. And so each one of these point estimates is risk adjusted based on the most recent model, the most recent statistical model, and it goes forth. So this example, this is a DSM, death and serious morbidity. And in the United States, as in many countries, a lot of the population is aging. And so this is a performance measure looking at only elderly patients, death and serious morbidity. The interval, you can change it. You could just say SSI, you can say mortality, you can say whatever you want. And the interval, you can have it, we put this for every 2 weeks. And you have a start date and an end date. You can talk about what kind of statistics you want, and then it gives you this risk-adjusted run chart. And so what it does is it looks at data longitudinally. You can do it for the last 6 months, the last 1 year. You could change the interval however you want. It's risk-adjusted, and it shows trends. Are we getting worse? Are we getting better? Is it just bouncing back and forth and we're doing okay? And it really helps to identify problems potentially sooner than the quarterly or the semi-annual report, where we're just waiting and waiting and waiting. You could do this like if the last 2 weeks something it got worse, and then this week it got worse, and then next week it got worse. You can see this trend that, we should do something now rather than waiting a few months for our semi-annual report. So this allows, and this is what a lot of quality improvement courses really champion, are these run charts, and then there are statistical lines that you can use for standard deviations above and as control limits or warning limits if you go above those lines. I'm sure you've seen those. So this is a run chart that really helps. How to support research with NSQIP. As I talked about before, we developed the PUF, the participant use file. And again, this is de-identified data. In most countries that I know of, that, patients don't want to be identified in all these. And so we strip out all of the patient identifying information, as well as hospital de-identifiers. There are things where, if there's one hospital in the United States that does the most liver resections, and they're tenfold higher than the next hospital, then we have to strip out the volume of procedures by hospital and things like that, even if we don't put the name or the state or where they are. So we look at very closely all of the variables that are in the PUF to make sure that things are as de-identified as possible. Sometimes we have to strip out data that might be very useful for analyses, but we strip it out. Otherwise, other than the identifying information, we keep most of the clinical variables that are very important for doing the risk adjustment and also for the outcomes. The way we have this is the participant use file is that anyone who participates in NSQIP can use this data set for research purposes, and we made it free for the users. We felt that this was a reason that hospitals will want to participate in the program so that they have access to this research database. We collect, before we give it out, we collect who is doing the research and what project they plan. We don't follow up with any of that, but we just have a record of who's using and what. And most hospitals do ask for the data and do things with it. The ACS, the College of Surgeons, we do not support analytics. So if they get the data and they say, hey, can you help us with statistics? No, we can't. And can you help us publish this paper? No, we can't. You get the data, you can do with it whatever you want, but we don't have enough staff support to do statistics and help them write a paper. However, we do conduct internal research at the College of Surgeons. So we have probably 15 statisticians across all of our quality programs, and some of them are doing internal research. And the internal research we do, at least within NSQIP, and we do it for our other programs as well, is that when we need to do something to improve NSQIP, if we need to do something to advance NSQIP, if there's a different way we want to potentially do statistics, or if we want to bring in new variables, or if we want to test things like that, studies, again, about analytics, new variables, or things like that, when we test those, we do that internally. We actually use the entire data set with the identifiers, but we keep it within the college. We do not share that data outside of the College of Surgeons. Sometimes when we start a new variable, for example, we were looking at disparities in research, and we tried to see if we can identify disparities and whether we could do a caterpillar plot with disparities and there would be outliers. So we use that data set to do that. And we then look down to the individual hospital levels. We can do that internally at the College of Surgeons, but we do not put that data out for people externally. So people externally cannot identify or cannot do by hospital, who's good and who's not good. Everything is together, and there is no hospital identifier. A new PUF is released each year with the most recent year of data. So whenever we release that, all of these researchers are just waiting until it's released, and then once it's released, they get the newest file. This is how we try to do that. To date, I just looked on PubMed, and I just put in the word search for NSQIP, and there were over 4,000 publications since we started this. Just to give you a sense, last year in 2022, there were 592 publications with NSQIP in the title or in the abstract. There's probably some that don't say NSQIP, but this is good enough for now. One of the great things about NSQIP, about all these hospitals doing this and within different procedures or different types of settings, or if they want to look at different types of populations like the elderly or so forth, is that we have collaboratives. So we have 50 different collaboratives in NSQIP, and they sign up with us, and they're usually regional collaboratives, like the state of Texas has a bunch of hospitals that work together, or there's a colectomy collaborative that all work on colectomy and usually surgical site infection and decreasing anastomotic leaks. We recently had a collaborative from actually the pancreas surgeons who did a randomized controlled trial using NSQIP, and they wanted to know if like antibiotic A was better than antibiotic B, and they did a trial using NSQIP, and we actually Most times we do these trials, it's very expensive. We did this one without funding, and all of the pancreatic surgeons got together. There were 30 plus sites, and they were very excited to do that. We had one site, Memorial Sloan Kettering, that was the official kind of core site that was helping to randomize the cases. So the case would come in, and they would randomize it to A or B. They would do that, and the data all was collected in NSQIP. And actually, the trial ended. It was stopped before the end of it because there were findings of one antibiotic was better than the other. And this was actually published in JAMA just earlier this year. But it showed us that we can do randomized controlled trials, which are usually normally very, very expensive because of the infrastructure needed to collect the data. But once we have NSQIP in place in these hospitals, we could run the trial without need for funding. And we showed here proof of principle that we're able to do that. Other things that we've done with research is the ACS-NSQIP risk calculator. I don't know if anyone uses that here in Korea, but if you go onto the college website, or if you just Google ACS-NSQIP risk calculator, this comes up. And this started as a research project. We had a research fellow, and we just said, hey, can you predict how a patient is doing if we put in all the risk factors? So if you can see this pointer, we can put the procedure in, like if I say colectomy, and then I say the patient is 50 and female, and all of these, I answer all these questions here, and I click on it. It gives the predicted risk for all these things. And it really helps us when we're talking to a patient, or it helps us, the surgical team, like, oh, this patient is a lot sicker than I thought. We need to get the ICU ready. We need to have the cardiologist ready. We need to do all these things. So it really helps us, the team that's taking care of the patient, or the surgeon taking care of the patient. It also helps the patient know, like, this is the risk. You are, this is all red. I just put in all the kind of bad risk factors. And this is all in the red. If they're going to do well and they're young and they're healthy, all of these turn to green. And if they're in the middle, it's yellow. So we have put all these in. And we also kind of have I call it a fudge factor. If the surgeon thinks that the patient is sicker than these variables will define, they can kind of move the bar a little bit, part of a standard deviation, to make the patient slightly sicker. So so this started off as a research project, and we're just like, hey, let's try and do this. How well can we do this? We did it with half the data. We validated it with the other half the data. It worked out pretty well. And so we've had this risk calculator. It is free for everyone to use. And we know that millions of people use it every year. And a lot of people outside the United States use this. And a lot of people who are anesthesiologists or internists in internal medicine, or we have this for pediatrics as well, pediatric surgery, use this. So we felt that this was really interesting and helpful. We also, and I'll talk about this a little later, we thought, well, is this going to be, if we put it out there on the internet, is this going to be helpful for patients? And so when we were testing this, we had a patient focus group to say, does this make sense to you? Do you like this? And so forth. And so this was made much more for the physician or the surgical team to use rather than the patient. But I think we are very much thinking about how to make this useful so that it's in lay terms that the patient can understand. Next question, does NSQIP help to improve patient care and outcomes? So if we develop this registry, which we did, and our hypothesis is that, we'll put this data, we'll give it back to you, does it improve outcomes? So very early on, we launched ACS-NSQIP in 2004. We had 2005 data, so we looked at the first few years of NSQIP. This was published in the Annals of Surgery in 2009. And basically, by Dr. Bruce Hall, who's one of the people who works part-time at the college and helps us with a lot of the analyses. The percent of the institutions that improved was 82% had a lower complication rate statistically, and 2/3 had a lower mortality rate statistically. And this was very early on in the program, and I do want to say that the initial hospitals that joined NSQIP at the first kind of couple years were the early adopters of this. And so they're the ones who were very motivated to do that. And I suspect what happened is that they got the data back and they acted on the data and they showed this improvement. We continued this. We probably 10 years later, we did the same analysis, and you can see that hospitals continued to improve over a period of 8 years. We did it at 10 years, so we only had the 8 years worth of data. And you can see here in the graph that certain things got better faster. And the three things were surgical site infection, UTI, and pneumonia. It just so happens that these started at higher rates, so they had more opportunity to improve. Cardiac issues and vent and intubation and renal issues were started at a much lower rate. And so there wasn't as a large of opportunity to improve. Same thing with mortality. So these are the lines that did improve, but not at the same rate as the SSI, UTI, and pneumonia. Not all studies have shown that there's been improvement, and there's some studies that people, when they look at NSQIP and they try to look at the NSQIP hospitals, did they improve or not, and some showed that they didn't. But a lot of these studies, unfortunately, use billing data, which we showed previously not to be accurate. So this one used Medicare data, and they showed it didn't work, but then also they used data that wasn't accurate. It's very hard for us to test NSQIP hospitals if it didn't work, because we only have our data, and so it's a hard thing to really test. But we do agree with the conclusion of this paper that feedback of outcomes alone may not be sufficient to improve outcomes. So if we just feedback the data, it doesn't automatically mean that that hospital will get better. And I think what happened is that after all the early adopters in the first few years of NSQIP joined, other hospitals like, oh my God, all these hospitals are getting better, we'll join NSQIP. But if they just get the report back and it just sits on the table and nobody does anything with it, then they probably will not improve. And I think that we're constantly up against that issue right now. And so the way I look at this is that there's kind of three types of hospitals. And we know that not all hospitals sufficiently act on the data or respond to the data or work with improvement. So if you talk about improvement, there are hospitals here that they get a report and they get better and worse, better, worse, better, worse, and they don't really do anything about it. And when we don't do much of anything, we just hope we get better. And so they don't really act on it. So that's one type of hospital. Unfortunately, we see too many of the hospitals in that sense. They don't get better, so they might as well not be in NSQIP. If it were up to me, like, you should just not do that. If you're not going to do anything with the data, just don't join NSQIP. The second type of hospitals that they do something, but then they keep on doing the way they've been doing it. So we see these hospitals a lot. They're just like, well, why don't you do anything different? Like, this is the way we do it here. This is what we do, and we're not doing anything different. This is the way we're doing it. And so they stay where they are, and they don't really improve, but they don't get worse. They just kind of stick where they are. It's this third hospital that are the ones that are the real inspirational ones, and these are the ones that should join NSQIP, should join a registry with accurate data. They continually work to get better. They standardize what they do, and then they innovate and they improve. They change something, they get better, and then once they get better, they standardize again, and they innovate again, and they constantly are working to get better. There are hospitals out there that do this consistently. They have it kind of like clockwork on the calendar, on the yearly calendar, or on a 2-year cycle. They look at their data, and when they see that there are opportunities, or they see other hospitals, and if they stand still and every other hospital gets better, then on the Caterpillar plot, they will get worse and worse and worse. And so once they do that, they have these collaborators, they hear what other hospitals are doing and these new things, these new ways to do things, and so forth, and they're constantly getting better. It is a constant kind of walking uphill to get better. So these are some of the questions that we get asked all the time. But even today, 2023, even after 20 years, there are several issues that exist that we continue to work on at the American College of Surgeons. So I'm going to share four of them with you. Just, the last 2 weeks, I've been working with our statisticians and our nurses and all the staff at the American College of Surgeons of these things. So first one is this. We are continually trying to expand NSQIP to address more domains of quality. So back 20 years ago, the biggest thing that we really wanted to address were complications. But there's more to quality than just a complication, right? If a patient has a surgery and there's no complications, it doesn't necessarily mean it's a high quality surgery. There's other domains of quality. So in the United States, we think about 6 domains of quality, and it's an acronym of STEEP, STEEEP. So let me share these with you. The first S stands for safety, and that means if the operation is safe, then there's minimal complications. No surgeon or no hospital will ever have 0 complications. If they do, then they're probably not telling the truth. We have never seen that in NSQIP in the 20 years that we've done it, and we have some of the best hospitals in the country. So we want to have minimal complications. STEEP, S is safety. This is why NSQIP was started 20 years ago. We're trying to expand NSQIP to some of these other domains. T is timeliness, so minimal waiting. And so this is a lot of times where, for example, emergency surgery, somebody with perforated diverticulitis comes into the emergency department. How long is it until they get to the operating room? Is it, within 1 hour? Is it within 1 day? Is it within 3 days? What is the timeliness of the operation? Diagnosis of cancer. A diagnosis was done in January. When do they get to the operating room if they're going to have surgery? And so timeliness is very important. Effectiveness. Does the operation achieve its goal? So if we're operating for cure, are we curing the patient? If we're operating for pain, are we minimizing, alleviating the pain? If we're for other symptoms, are we doing that? We don't necessarily measure that in NSQIP. A lot of this is just assume that we fix the hernia, that the gallbladder pain and the biliary colic goes away, the pain of eating goes away, or whatnot. The effectiveness. Efficiency. In the United States, we spend a lot of time looking at how much the care costs. Is it cost efficient? Is it high value? And value is defined as quality over cost. And so we a lot of times put in the money value of how much it costs. We have a lot of low value care where we get too many CT scans. Like a patient will be going to the operating room for a colon cancer, and we'll have had 4 CT scans within the last 2 weeks because they can't find the other CT scans, or it's from a different hospital, or so forth. And so how can we make the care more efficient? Equitable, that care is fair, that it's similar. So whether it's a wealthy or a non-wealthy person, is the care similar? If they're in the south of the United States versus the west of the United States, or in Boston, or Chicago, or San Francisco, or Los Angeles, is the care the same? Is there equitable care across all these different regions, or things like that? And finally, the P is patient-centered. And this is perhaps one of the more important ones of what's the quality of life and what's the quality experience. We use PROs, patient-reported outcomes. And so these are those surveys that we give to patients to say, rate your pain. We ask them to rate their pain before the operation. We ask them to rate the pain after the operation. And if we're operating to decrease their pain, is the pain going down? And everyone has a different scale of what pain is, and they have different tolerances for pain. So we use them as an internal control. We try to have multiple points of testing so that, maybe one day they're just unhappy and their pain is really high. But so we kind of get multiple numbers to do that. But patient-centeredness is one of the things that we're adding into NSQIP with some PROs, or patient-reported outcomes. A second issue that we're working with is, what data variables should we include or eliminate? When we ask surgeons which variables they want to collect, and we say you can only add 5 variables, they usually give us 25 variables. They want lots and lots of, they want to measure a lot of things. And it's great because we always want more data, but the poor data collector has to collect all these, and we can't collect everything we want in with the method of collection that we're doing. So which data do we keep and which do we eliminate? Outcomes, we're adding outcomes because we want to add more of the domains of quality, whether they're PROs, whether they're cost data, things for equity, things like that. We know that process measures are very important. So process measures are things we do. So you probably have heard of ERAS, the Enhanced Recovery After Surgery Protocol. And so there are usually about 10 or 12 components to the ERAS protocol. When we first started ERAS, and people at hospitals said, oh yeah, we have it all. The patient's eating the next day, they're walking, they're doing blah, 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 blah. And then when we would visit into their medical record, it wasn't true. So we figured, all right, we're going to put some of these process measures into NSQIP and see what the compliance rate is for these things. The compliance rate was usually around 50% or less. And so even though we write an order, even though we think we told somebody, even though we have it as a protocol, it doesn't mean it's getting done. So the registry tells us that it's getting done or not. So sometimes we really think about the process measures. Risk adjustment factors. This is very important. Everyone thinks there's a lot of risk adjustment factors. What we do is that we test them. And when we put in a risk adjustment factor, and this is some of the research that we do internally at the College of Surgeons, we put in the risk factors and then we model it out. If it is one of the most important risk factors, we usually keep it. If it's the 20th factor that goes into a model or less, even though it might be important, but if it's number 20 or less and it's not really going to make a difference, we don't add it in. So we do a lot of testing before we add in risk adjustment factors. Like some surgeons, in colorectal surgery, we think steroids are so important, but that comes in very late into the model. We think that other things are very important, but if they come in late into the model and they're not really all that important, we usually don't add it. And then the two other things, hospital characteristics and personnel characteristics, like the surgeon or surgical teams. Sometimes we add these in, sometimes we don't, and it's an ongoing discussion. We constantly think about validity. Is it the right thing to add? And feasibility. How difficult or not difficult is it to add? Some variables are very difficult to add. If we have to collect a variable after the patient gets discharged, it's much more difficult than if it's in the hospital medical record. We try to prioritize parsimony. So that means we want to kind of keep only what is absolutely needed. Not to have any luxury variables or bells and whistles. We want to keep it absolutely what is needed. And then if it makes it really small, we can add in some more, then we can add in some more. But we really tried to keep the most parsimonious data set available. Third, how do we collect data more efficiently? So the data collector is a human being, and they can only do so much, working 40 hours a week. In the United States, with the number of variables and the way they have to follow the patient and our healthcare system, a data collector can collect 1,680 cases. That's what we say, 40 cases every 8 days. If we can make it more parsimonious, we could probably increase that number. But if we can automate some of it, that would be even better. So we seek more automation of data into the registry while maintaining accuracy, and that's a really important piece. However, as we've done this, and we've been trying to do this for the past 10 or 15 years of automating, there are definitely different definitions of automation. So for example, there's a word find. So if you're using a at least in the United States, a word processor like Word or WordPerfect. And if I say find every time I use the word quality, the software can find every time that there's the word quality in it, or just find this word. And if we did that for the medical record, they can find the word. So every time, and we worked with these companies, like we want to find if this patient had a pneumonia or not. And what they did very easily was like, well, they looked for the word pneumonia, and they said, yes, there's a pneumonia here. That doesn't mean that the patient actually had a pneumonia. It could say no pneumonia, or is the medical student who doesn't know what a pneumonia is typing in pneumonia. And so there were a lot of problems with that. And so this was not accurate enough. This word find, that's not a good strategy. Don't go down that road. Coded data. So they're like, well, if we build for it, then it must be there. And we already proved that the coded data is, I don't want to say anything that goes on for billing and for money pieces, but it's usually not accurate enough. There are some coded data that are good. If the patient dies, the coded data is pretty good. The payers know when the patient dies. They stop paying for it. And so they're very good at that. They don't know SSI, things like that. So it's usually not very accurate, but there are some things that are good. Mortality, length of stay, if they get readmitted, those are good things. Structured data. One of the problems in the health record is that there's a lot of free text. We type and we just kind of say in our own words what the patient had. It's not menu driven or whatnot, but increasingly more we're trying to have structured data. We can only put in a numerical data when it's a number, and we can only do it to 0, 1 decimal point, and it's all structured and it's all standardized. This makes it much easier for the computer to get the stuff out. And so right now we can get structured data out automatically if it's the laboratory value, if it's patient characteristics and demographics, things like that, the medication and the medication dose. If we want those things, those can come out. The things that we write in free text, like a complication or our thoughts on something, that's not structured in the United States, and so we cannot get that out as structured data. So it's variable for that. And then number 4 are the kind of the things that are really cool that are happening now with informatics, which is natural language processing or machine learning. I don't know. Do you have ChatGPT? Use ChatGPT. So ChatGPT and kind of can figure out what we mean when we have free text there. And so a lot of companies are saying that we could do that if we could use machine learning to learn which patient has a pneumonia or not, and not just word find or not just a code or whatnot. But the issue with this is that the computer companies, the software companies need a gold standard to teach the computer what a pneumonia is and what it's linked to and what characteristics are there and so forth. And so we are working with some companies now, one of the offshoots of Google and Microsoft and so forth, to see whether we can teach the software with the versions of NSQIP that we have to use natural language processing and machine learning. So in this one, we're kind of still waiting to see whether we can do the automation in that. There's other options, and when we talk to all these informaticists and all these computer engineers, they're kind of dreaming up things, but we're actually just still waiting about the automation. We do continue to audit hospitals to validate accuracy, and this is what I was talking about before. We want the interrelator reliability, or the percent disagreement between what they find and what we find. We will abstract that same record that they do, and if it's 5% or less difference, they pass. And so we can see very early on that that things got better and better. And the reason I'm talking about this now is that whatever automation technique we've been trying, we do this same thing. We do the same audit of validity of what they find of the accuracy. And so we can't assume that they're highly accurate. Most informaticists tell us that it's really, really accurate, but when we do this validation test, it's not always so. And collecting inaccurate data quickly still gives us inaccurate data. So just because we get it into the registry faster doesn't mean that it's any better if it's still inaccurate. And then the 4th thing is this, that there are too many quality improvement projects, quality improvement efforts that are conducted poorly. So we know that if we tell a hospital, like, all right, your infection rate is too high, and then some of them say, okay, well, we'll try harder. Next time it'll be better, and it's usually not better. There are some hospitals that are better than that, and they say, all right, we're going to start trying to do a quality improvement project. But not everyone is trained formally how to do quality improvement projects. And when we evaluated all the projects that are being done, they are not done well. They need to get done better. If you do a quality improvement project poorly, it is unlikely that you will get better. In order to get better, you need to do a quality improvement project well. So how do we improve improvement? How do we improve QI projects? So we've been developing for the last 2 or 3 years a quality improvement framework that makes it much easier for the frontline surgical team to conduct improvement projects. And so that's something that we've been working on for a long time. And we're studying how we can improve the conduct of the improvement project. So if you have a surgeon, and a lot of our surgeons don't have formal training in quality improvement in the United States, and they're just like, well, I can make it up, I'm really smart. They are really smart. They can try to make it up, but it's better if it's done right from the beginning. And so we have this framework, and we're trying to figure out how we can help our surgeons and our nurses and our anesthesiologists and our pharmacists to conduct these things better. And then whether, if they conduct it better, do they get better? Do they have better care? Do they have better outcomes? So this 4th thing is we're still studying this right now. We're working with a lot of centers. We're working with folks in the UK who are experts in quality improvement to really figure out how we can more effectively and efficiently conduct improvement efforts. So those are 4 things we're working on now. I'm going to end now in this last kind of 3 slides. Just as I think time is almost up, but some possible additional things that if I were going to start a registry like you are here in Korea, the K-QIPS, these are things to consider as it's being developed. So I cannot stress enough the importance of consistency and standardization. And so I understand that you're going to have kind of 6 different kind of buckets of procedures and the way you're doing things, um, and leaving it up to the experts to kind of decide things. It'll be really important to, yes, let the experts decide what variables are important or whatnot. It'll ultimately be decided by data to see what risk adjusters there are, by the definitions being used, and whether that can be done with audits to see the validation of these things, but also to consider having an oversight committee so that each of these buckets have some level of consistency. And I'll give you an example. In the at the College of Surgeons, we have over a dozen different quality programs, and we didn't have an oversight committee as strong as it needed to be. And so when we were doing, for example, readmission, even though readmission seems like it's such an easy variable to have, we had different definitions of readmission. Uh, so is it a readmission if they come back within 23 hours? Is it a readmission if it's just Monday to Tuesday? Is it when does the clock start? Is it at midnight or is it at 6 a.m.? Is it, all these things that you would think like, wow, I would never have thought of that. They came out to be when we got different rates of even readmission within 24 hours, that or within the next day or within 24 hours or so forth, that we didn't have an oversight committee to ensure that things were apples and apples, not apples and oranges. So the oversight committee to ensure consistency and standardization across the groups and procedures, the variables themselves, the definitions themselves, in the span, in the idea to get parsimony. Some groups kind of got rid of some variables, but others used them in the models, and so that needs to be kind of figured out, and it'd probably be really helpful. Second, the statistical techniques, keeping the variables there, keeping them same definition, but also how the statistics are run and how the models are developed are really important to do across these, because if you use different statistical techniques, you might get different results, and you don't know that the differences by procedure are because the results are actually different or the statistics are different. You might have different p-values, you might use different cut points, you might use different model techniques of how stringent or not stringent the risk adjustments are. It will change the results, and you want to make sure that if there's a difference, it's a clinical difference and not a something borne out by different statistics. The third is that the consistency in terms of prioritization of the stakeholder perspectives. So we at the American College of Surgeons, we think that the surgeon is very important, but we also know that the surgical team is very important. The hospital is a different perspective and very important. The government or the payer is important, and the patient is very clearly very important. If you design things for each of these different stakeholders, you will get a different answer. What the patient wants to know versus what the surgeon wants to know, how you prioritize these things will be very different. How you report these things will be very different. Doing it consistently amongst all the 6 different groups will be very important. Deciding which perspective you're going to give back the data or use is very important. You might do multiple things at once, but that has to be messaged well. Our oversight committee ensures that, how we're doing things is consistent amongst these things. So, as an example, and this may or may not be relevant, but let me give you an example that will hopefully clarify this. If we are developing a reporting program for a patient, and we want to say, all right, we're going to give you these 100 hospitals, and we're going to tell you who are the 10% really good hospitals, the 10% really bad hospitals, and the 80% in the middle. For a patient, if I were a patient, I would want to know that. For the College of Surgeons, who are trying to work with all of these surgeons, we might not want to put that out to the patients. We might tell the surgeons themselves, and we might not want to share it with all the surgeons. We might want to tell who are the kind of below, average surgeons and help them get better, because that's our responsibility to the surgeons. And how do we do that and not necessarily put out that data into the public? So depending on the perspective and depending on who the stakeholder is that you're kind of developing these things for, and how you message these things will be very important. And the reports might be very different depending on who the different stakeholder is. Having an oversight committee to decide these things so that it's consistent amongst all the six different groups will be vitally important. When we did not do this well enough at the American College of Surgeons, and we had all these different ways of doing things across all our quality programs, we were sorry that we didn't have stronger oversight and stronger consistency amongst all the programs. And the fourth thing is the feedback reports, to maintain consistency of being able to be clear. Sometimes it's clear to me usually when I write the report, but it might not be clear to anyone else. That it's actionable. That's probably one of the most important things, that if you give back a report and there are, hospitals that need to get better, it makes it very clear that they need to get better and how they might get better, what to do, and what the stakeholder perspective is. And then something that we do we spend a lot of time on when we develop new programs at the American College of Surgeons is that how will success be evaluated? So I'm always asking our staff and all these expert surgeons that come in that, all right, we can develop this now, but in 3 to 5 years, what am I going to look at? What analyses am I going to do to show us all that this program was successful? Because if it's not successful and we develop something and people are spending a lot of time doing this and it's not successful, it doesn't change anything, we should just sunset it. But most times we do put in all this work, things get better, or we have hypotheses that these things are going to get better. What are those things? So for K-NSQIP, and if I was thinking about if we were developing this now in the United States, what metrics would be used in 3 to 6 years to show success? So number one is that we were able to launch the program after all this time of thinking and getting all the variables together and getting everyone to agree or not agree, and surgeons are usually very agreeable. I'm just kidding, not all surgeons. That if we officially launch a program, we celebrate it and it's a success. We do that with our programs now. We just launched one for vascular surgery. We think it was a launch that was a win right there. Participation numbers, the number of hospitals. If we say that there are 5,000 hospitals in the United States, how many hospitals after 1, 2, 3, up to 6 years have joined? Participation numbers of surgeons. Just because a hospital joins or a team joins, are all the surgeons agreeable to join? Another society in the United States is the thoracic surgeons. A lot of times they join a program for thoracic surgery, but not all the surgeons want their data in there, and so not all the surgeons join. Number of cases. What are the number of cases that are putting in? The percent of total cases in the country. So if there are 10,000 pancreatectomies done in the country, how many of those 10,000 do you have in the registry? That's another metric. Quality reports developed and distributed. We developed this quality report. It went to 1,000 hospitals in the last year. That could be a metric. Number 7 is probably the biggest metric, improvement in results. If the infection rate were really high when you started, you put this program in, you help people get better, and it's really low in 5 or 6 years, and you are sure that this is what helped that. Number 7 is a great metric to have. Number 8, collaborative reports. And so if this is part, and this is going to be discussed, and the data are going to be discussed and put out into meetings, and surgeons are meeting, and the surgical teams are meetings, and their discussions and projects and conferences that are being done together, that is another great metric to use. And then research, if advancing a number of research studies. And so that's one of the reasons we collect this information when we give out the PUF, and the number of presentations or publications using K-NSQIP is also another metric that could be used. So these are just 10 that came off the top of my head. I'm sure there's many more. I'm sure you probably already thought about these already, but I think that this is very important, because especially if this is being funded and the funder is saying, well, and after 5 or 6 years, you want to get more funding because you want to expand it and do it in other things, to show that the first kind of foray into this was successful. What are the we call KPIs, the key performance indicators that this thing is successful. So thank you, and I want to say that I'm very happy to be available for any questions today or anytime in the future, and I'm very happy to share any information that will help to make K-NSQIP successful. I have been working in quality evaluation and quality improvement my whole career, and it's very important to me, regardless of whether it's in this country, where I live, or any other country. I think that this is something that we as surgeons and surgical teams need to do for our patients. And so, however I can help make this successful, I'm happy to do that. So thank you very much.